to get. So there was some preparation on the lectures, but it's interesting because every time when I'm wondering what I'm going to do, I just sort of went through the patients that yesterday or the day before had come in, and there was another question this morning about some of the issues that we want to talk about. So first and foremost, very interesting question, and this came up actually in Pastor Robles group meeting too, was how does my body know when to stop losing weight? And so the way you want to think about this is that I'm not sure if there's any magical mechanism in the background other than the fact that what occurs is a fine balance between two different variables. As I've said repetitively in the past, obesity is a genetically predisposed condition which can be superimposed with activity level and dietary discretion or indiscretion, depending on which side we're looking at. And so with increased activity, we may be able to compensate, and with increasing our dietary, we're making dietary choices, we may be able to offset our genetic predisposition. So this graph, it's sort of crudely drawn. On the x-axis, on the horizontal line, as you're going, that represents the time, and on the vertical axis, it represents the concept of basal metabolic rate and energy absorption and energy expenditure. The red line represents our energy absorption at any given point in time after surgery, and that purple line represents our basal metabolic rate. So if we go to the leftmost side of the chart, Brad, do you see my cursor on there or no? There's no cursor. All right. So if you go to the the left edge of that graph, the red line at the bottom represents the amount of calorie that I absorb the day of the surgery, and it's very little, clearly. And the purple line represents, at the top part of it, represents the amount of energy my body needs in the form of a basal metabolic rate. So today, if I weigh 400 pounds, my basal metabolic rate, the amount of energy that I need to absorb to stay functional, it's, let's say, 4,000 calories. I'm not making these numbers just for the sake of, make the math easy for me. So at 400 calories, I need, at 400 calories, I need 4,000, let me start again. At 400 pounds, I need 4,000 calories, and that's the top of the purple curve on the left-hand side on the left. And since I had my surgery this morning, the amount of absorption of the calorie is at the least amount. All I got was an IV fluid, about 200 calories. So the difference between the top of the purple line on the left upper part of that graph and the amount of energy that I absorb at that, which is the lower end of that graph on the left-hand side, the red dot, the red line, is the greatest. And so my body will go to its stored energy spaces and then start draining energy from the stored sources, and it will come up with the difference between 4,000 calorie that I needed versus the 350 calorie or 400 calorie that I got from the IV fluid. So the balance is 3,500, and 3,500 difference in the calorie is brought in a form of stored energy. That stored energy has some weight associated with it. And as that weight is converted to energy, my weight goes down. So tomorrow morning, now I weigh, a pound less, for example. And so my basal metabolic rate is 1 pound less of what it's needed. And at the same time, on the red line, my energy absorption has gone up because now instead of 1 bag of IV fluid, I'm having 2 bags of IV fluids plus a little popsicle, for example. So if you sort of fast forward these two, you can see that the purple curve and the red curve towards the right end of that graph get very close to join to each other, and that time frame is about 18 months or so. So if I sort of do basic standard stuff, and I'll elaborate what I mean by that, at some point my basal metabolic rate, which is the purple curve, will meet with the red curve, which is my energy absorption. At that point, my weight stabilizes. And usually, as I said, that point occurs at about 18 months or so after weight loss surgery. So what are the things that I can do to manipulate this curve? There's two examples of it. So if I really start exercising a lot, what I do is that though I keep my basal metabolic rate higher. And by keeping my basal metabolic rate higher, as you can see the cartoon of the exercising people, then I move the graph, instead of being on the purple path, it moves up to the green path. So what that does is that extent, even though it may slow the weight loss down, because it converts more fat to muscle, it essentially allows me to build healthier weight and prolongs the length of my weight loss from 18 months to 24 months, and eventually it will be at a lower set point, but at a healthier weight. And most patients will experience that they'll lose some rapid weight loss early on. Then when they get to it and start going to the gym, they'll say it's interesting because I've noticed that the scale doesn't move, but my shape changes. The clothes is tighter fit, my pants are smaller, but the scale number doesn't change. So this is how it's represented on a graphical curve when you look at the numbers. How can I manipulate this curve? Would be to have a whole bunch of chocolate. And chocolate as an example of carbohydrate or sugar that can be absorbed. If you take at any given point in time food ingredients that are easily absorbed, then the amount of food that's taken is much closer to the calorie of the food that's absorbed. So this would be an example of comparing a certain volume of fat or protein to the same amount of carbohydrate, where the carbohydrate will get absorbed easier. So if I was to have a whole bunch of chocolate early on, the chocolate, because of its simple sugar nature being absorbed easier, it will have me intercept the purple curve earlier, essentially hitting a plateau much sooner, which is why practically when we see patients in the office and we talk about, well, I don't know if my weight has slowed down and I'm sort of exercising, with a little poking and probing, we can all agree that more often than not, carbohydrate tend to be one of the things that we can always address relatively easily by looking at this. Is if you have carbohydrate, you can see that it intercepts the purple curve earlier. The overall message from this is that the fine balance between basal metabolic rate and calorie absorption, not calorie intake, but calorie absorption, is what will dictate eventually where my weight stabilizes. I can drive up my basal metabolic rate by having more muscle mass and be vigorous in my activity level. And I can keep my calorie absorption in a form of an absolute calorie that may not be structural protein by trying to keep my carbohydrate volume down. I'm not talking about some of these exotic discussions that are now going on and patients asking me about this ketosis or starvation diets and so forth. I'm just saying in the order that we've always emphasized: water, protein, everything else. Let's emphasize the protein and try to keep the carbohydrate and fat to reasonable and normal volumes. Any question on this? Very good. Alcohol is very easily absorbed as a type of sugar, and you can just have a glass of wine, about 200 calories, and now we've pushed up that basal metabolic, pushed up that energy absorption curve by 250 calories. So if I need to offset that, I got to get on the treadmill for about an hour. Not worth it anymore. All right. So I'm going to move on. So we're gonna these are three long slide series, and I'm gonna sort of try to not put everyone to sleep. But I think it's important to revisit some of this information. When we're talking about carbohydrates, we're going to talk about what carbohydrates are, um, what is the definition of simple sugar versus complex carbohydrates and starch, how is it digested, and the metabolic overview. Carbohydrate, when we first link, is in the food chain. Essentially, photosynthesis, which is sort of plants store some of the sun's energy, and they go through a whole bunch of chemical reactions, and the carbon dioxide and water forms a carbohydrate base, essentially Lego components, and this is eventually converted into a source of energy. And carbohydrates, essentially all plant foods have carbohydrate in them. It's part of the processing that we take the carbon dioxide and the water, and essentially makes it carbon-based environment for us. Depending on where we live, interestingly enough, carbohydrate or driven food sources may be different proportions of our dietary intake. Eskimos have about 8% of their diet come from carbohydrate, and whereas 70% of the third world countries, the energy source for their diet is from carbohydrate. It's sort of, when I was putting some of these slides together and I was sort of going through them again, it came, an obvious thing comes up is that it's interesting how we always talk about, low carbohydrate diet is supposed to be protective against obesity and all that. And this sort of goes in our face, where Eskimos have a very low carbohydrate diet as a proportion of their total caloric intake, yet there is a fair amount of obesity and excess weight problem in Eskimo population. Highlight of this would be genetics being an element of this, and second most is that we can't really just simplify everything to avoiding this and avoiding that is going to solve everything problem. There's multiple issues going on. The cell function, it's an energy and it's used by all cells in the body. What's very critical about carbohydrate is to appreciate that carbohydrates are absorbed very easily and are broken down relatively easily too. Certain cells that need rapid processing of the energy use the carbohydrate as a form of source of energy. Red cells, the brain cells, can only use carbohydrate until a starvation phase is set in which case the brain changes its substrate for energy sources to ketone bodies and so forth. And but those transitions are long-term invasive. Our brain does not have the capacity to be able to go from sugar consumption to something else between today and tomorrow. So carbohydrate function is needed for effective burning of the fat. So I think on one of our previous slides, I sort of scanned, I'd gone over it relatively quickly, not necessarily highlighting this, but if we think about the Krebs cycle, the Krebs cycle is essentially where the fat, carbohydrate, and protein all fit into the loop. And the bottom line of that whole big circle is that though, if you do not have the carbohydrate feeding into this at some point along the curve, you get a breakdown of the whole pathway and or significantly becomes inefficient. So in general, which is why you can't really think about having a patient go on a completely free diet of one element or another. Spares protein from use for energy. And in our weight loss surgical patients, we always emphasize overdoing the protein is going to help prevent that. And fiber alternative forms of carbohydrate in general may provide a form of benefit, and we're talking about things such as prevention of constipation and cancer and antioxidant. What's to elaborate on this fiber element is a large bowl of cabbage and spinach and lettuce may be healthy in an intact GI tract, but the same diet in smaller volume can cause havoc in forms of gas and excessive diarrhea in a post-DS patient. So we really need to be careful where a patient may come in the office and say, I'm really not having a lot of carbs, but I'm not sure why I have a lot of gas. It's like, well, the salad is essentially a form of undigestible carbohydrate that I'm having in a form of a fiber, and that may be causing the problem. Carbohydrates in general will differ in types of the building block. There's three main ones, and we'll talk about it: the size, as to how many pieces of these Legos are together, and how strongly are those blocks connected to each other. All of them determine how our body is able to break down or not. So saccharide essentially is the building block of it. The simple saccharides are the sugars. They can be one or two or three of them together: the monosaccharide, disaccharides, and trisaccharides. Complex carbohydrate in a form of starch or amylose. There are multiple of those simple saccharides that are connected with each other with single bond. And then you may have complex carbohydrate, which is essentially that when we get into a form of a fiber, where there are different bonding than starches, which makes it essentially, for the most part, an undigestible form of carbohydrate to us, where in certain animals may have the ability to be able to break down the bonds of the fiber between those pieces of the saccharides and are able to tolerate the fiber, where our GI tract doesn't have the enzymatic capability. So monosaccharides, let's go back again one more time, and mono means single, saccharide means the sugar. Examples of the monosaccharide is glucose, simple sugar, essentially table sugar, most abundant carbohydrate. Fructose, mostly found in fruit and honey, and part of the simple sugar, or galactose, which is part of the milk, generally not found in the form of a nature. Then when you take some of these sugars, simple monosaccharides, again going back one more time, monosaccharides, and you join them together, you get the disaccharides, which is here. So a glucose plus a fructose forms a sucrose, which is a table sugar, maltose, which is a glucose plus a glucose molecule, and lactose, which is glucose plus a galactose molecule. So I'm going to go back one more step again here. And if you remember, galactose is a part of the sugar. And since I cannot have lactose because it'll give me a lot of gas, but at the same time I'm tolerating sugar, guess which part is not that I'm not able to digest or break down is the galactose. And going back again, that's sort of part of the sugar milk that is generally not found free in the nature. So we went from a monosaccharide, which is a simple single unit sources of the sugar. We take one or two of these together. Well, we take any pair of two of these together and we form disaccharide, the sucrose, maltose, and lactose. And lactose is what most patients may be lactose intolerant. And if they're lactose intolerant before surgery, they are for sure lactose intolerant after surgery. Polysaccharides is when you take multiple glucose or other monosaccharides and join them together. Starch and amyloids, many glucose storage for energy in the plant, and fiber when different kinds, some with multiple glucose units with different chemical bonding are connected to each other. And an example of them will be cellulose or pectin. And essentially, without getting into details of the biochemistry, what happens is that if you have a glucose and a glucose molecule and you have, let's say, one pair of arms holding them together versus two pair of arms holding them together. So if you have two chains connecting together versus one chain, that's the difference between a polysaccharide that's starch versus a fiber that doesn't, or our body doesn't have the ability to digest it. Fibers, often the structured carbohydrates are in plant, and which is why from a plant molecule there are more animals that have the enzymes to be able to break down those plants. Glycogen, storage form of carbohydrate in animal. It's essentially multiple glucose units together. It's very highly branched to aid release. So essentially, if you think about the glucose molecule, you can take these one Lego pieces and you can just connect them one behind each other, and you can get this long chain, which makes, and if you have to do that, you sort of use multiple ropes to tie them together. So you have this long chain with multiple connections to each other between one to the front and one to the back. So there's in length, and that makes it very structurally tough thing to digest and break down, and you have a fiber. Whereas glycogen, which is used in humans and animals to store them, instead of having one Lego connect to one at the front and one in the back, you have the same Lego by single bonds sort of connect itself to multiple glucose molecules. Think of it as like a snowflake, where you can have it sort of expand in multiple multiple directions. What that'll do is when it comes time to release the energy, because there's so many surface area and you can break down individual bonds by releasing multiple glucose sources, it becomes much easier to process that as a rapid source of energy. And glycogen essentially is the first go-to place when our body has excess calorie and carbohydrate to store in the liver. And it's the first place to go to when our body is in energy deficit, to try to mobilize it, just because of the fact that it's so easy to get a quick source of sugar released to get the energy to us. Extra glycogen that gets stored in the liver is essentially also the first stage or first phase of what is the fatty liver, when the liver stretches, because glycogen tends to get stored in the muscles and in the liver. When you I don't do this. I don't believe there's really a lot of justification for this, but for surgeons that recommend that a patient should go on starvation mode for 2 weeks before surgery, before they have laparoscopic procedure, at the theoretical level, at least, what they're trying to do is that they're trying to force the liver to utilize all of its glycogen stores, to try to shrink the liver by some degree, to try to get the most that they can out of the to reduce the size of the liver so that they can get more room to operate. Again, very little science to it from a practical perspective, but this is sort of what the theory behind that is. I think it's finally coming out now. Yes, it is. Better late than never. So do you guys want me to start over again? Yeah. Sorry about that. So glycogen store, as I said, liver and the muscle are the primary places. As a single organ, liver is the largest organ in the body where the glycogen are stored. The muscle is the second most abundant source of the glycogen, in a sense that there's more muscle, so there's more of it stored. But as a single organ, liver has the most amount of glycogen stored to it. And note that our brain needs about 150 grams of glycogen or carbohydrate on a daily basis to function. And as we talked on previous slides, you can't really process in an acute setting to have the brain functioning with anything other than carbohydrate. Anything on this before I go to the next slide series, next series of slides? Yeah. What was that? Oh. So on this second series of slides, we are going to talk about glucose pathways as to how they're converted, aerobic versus anaerobic energy pathway, hormonal control, and the carbohydrate food sources, and the implication of that when it comes to weight loss surgery, and specifically different modalities of diets and things like that. Some of the major hormones that we need to think about is insulin, Um, Insulin, it's made in the pancreas. Its job is to lower the blood glucose, increases all energy stores. Insulin's job is to try to lower the blood sugar to a normal level. And in order to do that, it mobilizes and it pushes at the very first step all of the sugar from the bloodstream into the cells where the receptors are located. Secondarily, what happens within those cells, then a whole series of metabolic processes take place, and the end result is that storage of the sugar that's taken in a form of energy, wherever that may have to be. Glucagon, and this is not glycogen. Glycogen is the source of multiple glucoses. Glucagon is made also in pancreas. If you want to think about it, you want to think about as the glucagon as the anti-insulin. So insulin lowers the blood glucose and glucagon increases the blood glucose. And its job is essentially to prevent the blood sugar from dropping too far down. Physiologically, we will all assume that, well, if I'm not eating anything, my body produces no insulin and no glucagon, and then they wait till the blood sugar goes up and down, and then one of those chemicals will be secreted. In fact, that's not how it happens. And there's a number of different metabolic pathways in our body that work in this way, where usually the one particular hormone and the anti-hormone are secreted at the same time. So at the baseline, our body produces and releases insulin and glucagon 24/7 in our bloodstream. What happens is then, if my blood sugar drops down too far, it's much easier for the mechanism within my body to pull back on the insulin secretion to let the glucagon that's already released to work, versus if it starts at the baseline 0 to start pushing out the glucagon out to bring up my blood sugar down. So the importance of this is that, as you'll see on one of on the next series of slides, is that if this imbalance gets too out of whack, as it would be in diabetic patients, and we're also continuously adding exogenous insulin, some patients do experience a significant weight gain, even though their diabetes is better controlled. And that has to do with the fact that essentially the job of the insulin is to store energy. And because that balance of insulin and glucagon is taken out of its baseline in physiologic state, now we're not able to process the energy absorption, and it's storing it as a form of extra calories. But it does that as a side effect, because it needs to take the glucose molecules in. So glucagon is made in pancreas, raises the blood sugar, it decreases the adipose fat and liver glycogen stores. So glucagon, glycogen is the multiple glucose molecules attached to each other. So I had too much stuff. This insulin takes it and stores it in my liver. And now when I'm not eating, glucagon is released and it goes to my liver and releases all of those sugars. Epinephrine, which is released, sort of the adrenaline, it's released from the adrenal glands and all the different organs. It's made in the adrenal gland and released. It raises the blood sugar and decreases all energy stores. And so this epinephrine or adrenaline, in a form of a medical school lecture type of thing, we always think of it as what's known as the fight or flight chemical in our brain. Is when you want to run away, you have a high heart rate. So think of it, it'll increase your heart rate because your body needs the energy to run away. It will also raise your blood sugar because your muscles need the blood sugar to function. And at the same time, you don't need to worry about storing the energy away. So it'll drive down the energy stores down. Let me see if I can do this. So this is, you can see it, okay. So this is essentially an example of what happens when we're talking about the top part of this slide. Can you see my cursor now? Still can't see. So the top part of this drawing is essentially a side of the blood vessel. So and the bottom part of this drawing is inside of a cell, any cell that uses the glucose molecule. So when I have glucose or sugar that's floating through the mechanism that was sort of briefly went over earlier, the insulin is released. Insulin comes and attaches to the insulin receptor through a whole bunch of chemical pathways. There's a penetrating arm to the insulin receptor. There's part of it that are phosphorylated. That sort of essentially forms a receptor, and the receptor allows a channel to be created for the sugar molecule to go from blood vessel to within every cell. And in a case of a type 2 diabetic patient, you still have the mechanism to create the receptors, and the receptors may be available. The problem is that there's something blocking on the insulin receptor, so even though you have the insulin, you're not able to get to the insulin receptor. And in a healthy individual, you will have the GI tract coming, the glucose coming down in the GI tract. It gets absorbed. Now we have the glucose within the blood vessels. The insulin is absorbed, is secreted into the bloodstream, and then the end result organ, usually being the muscles and the liver, is where you have a matching number of glucose that's being absorbed with a matching number of insulin that allows for the blood sugar to go down. So you have very little glucose floating in your blood circulation. In the case of a type 2 diabetic patient, the bottom one, you may have the same number of glucose being absorbed. You have the same intensity. You have the same response at the same intensity from the insulin for the matching amount of glucose that's being received. So if you just look at the left side of this drawing from the top and the bottom, you still have the same amount of glucose and insulin being released from both, and they are also the same amount within the blood vessels. The problem is on the receptor end of it is that you have an excess amount of insulin not being able to absorb the glucose within the organ. The end result is that if you, off of all of the glucose that you had floating, more of them end up being in the blood vessel. And the end result is that you have a disproportionately higher level of insulin and glucose in the blood circulation. You're comparing this to type 1 diabetes. Again, the top graph is the same when you're talking about glucose and insulin. Glucose gets absorbed. It's now in the blood vessel, insulin is there, and this allows for the cells, for the receptor to open up, and you move all of the glucose into the liver or the muscle. Whereas in type 1 diabetic, unlike the healthy and type 2 diabetic, you just don't have enough insulin. So even though your receptors may be working, you do not have enough insulin to mobilize the sugar. So you have a disproportionately more sugar that circulates continuously in your bloodstream, and that manifests by elevated hemoglobin A1C and so forth. What happened? So the daily carbohydrate intake, these numbers are what I taken on some time ago from the NIH guideline as an RDA, the whole triangle thing. And I think our understanding has changed. Significantly more is that the total carbohydrate intake as a form of a kilocalories is to be more than 55%, sugar much less than that, and fiber should be the bulk of that in the form of a gram. And then an average fiber content, again, we need to be careful with this, as this is sort of more of a generic recommendation. A duodenal switch patient will have to be mindful of the implication of having a high fiber when it comes to the gas and diarrhea. And the gas doesn't really cause a lot of significant issues other than just, it's gas. But we have to be mindful of a significant amount of loose bowel movement, not only because of the functional and the social issues it may bring in, but also from the fact that excessive frequent diarrhea will deplete the body of not only the water, but also of the electrolytes and so forth, which have to be replenished. So the average fiber content in fruit, vegetables, and whole grain, legumes of not a rice, but the beans. And serving examples is a small apple versus a banana, slice of bread, and sort of beans and lentils to provide the grams of fiber as a form of an average percentage of the fiber. And if we go back on the back slide, sort of trying to aim for 20 to 30 grams. Pyramid and the fiber, I have said this as joke to some degree, as to, most of us have seen that famous dietary triangle. And I think I've jokingly said this to dietitians, colleagues of mine, that if that triangle worked, there would be no epidemic of obesity, because everyone is supposed to eat this and this, and our entire food processing has been, or diet has been placed into that pyramid. There's a lot of flaws in that, but looking at this from a pyramid perspective, the 5 whole fruits and vegetables, 10 grams, 6 whole grains ends up being 12 grams. So total fiber, 22 grams, and 1 serving of sort of lentils or things like that is about 27 to 30 grams. Again, this is more of a nutrition educational discussion versus a guide for the duodenal switch patients, what to eat and what not to eat. Any question on this? And I'm going to pull the last. Let me see the third one. Where is it? You can't see me. No. Oops. Hold on. Right, Houston, bear with me for a sec. Right. This is what I need to do. So this is the third of the three series of the talk about carbohydrate. We talked about the basic terminology, how different molecules are formed. We talked about some of the regulation between insulin, and we're going to get a little more detail about different individual problems and pathways. Sources of the sugar and carbohydrate, the health issues associated with the fiber, the abnormal carbohydrate metabolism in different conditions, and last but not least, my pet peeve, the source of sugar and artificial sweeteners. Sources of the sugar, some very interesting numbers. The 45 off of all the sugar that we consume, 45% of it comes in the form of a processed food. So I think it'd be a good exercise for all of us to, every time we buy anything in a grocery store, look at the label and then see how much of it has something along the line of from concentrate fructose or high corn syrup or one of those things. And essentially that adds up to about being 50% of our processed sugar intake. Beverages, it's about a third of it. And there's some statistic now that in the last 2 years or so, Coke and Pepsi have reported that the carbonated drink in form of sodas, both the regular and the diet consumption, has gone down. And about around a third of it is what is considered in home use. This is what's described, at least in the dietary world, in the form of jams and coffee, sugar or baking stuff that we do at home. But bulk of it is in the form of a processed sugar out. So taking 12 ounces of the water and 10 tablespoons of sugar on average, we drink that, and that's about a can of Coke with about 160 calories. That's empty. And as is brought up here, this is just like sort of like an alcohol drink. You get it to get absorbed, and your body doesn't need anything to process it. It just gets absorbed, and now I have to find a way to burn 160 calories. And so what's the difference between the white sugar, brown sugar, honey, and sugars that are in form of a fruit or milk? So as we talked about, so white sugar, sucrose, which is a glucose and fructose molecule. Brown sugar is 97 sucrose and molasses, and honey, which is glucose and fructose. Fruit and milk. Fruit or milk have lots of other nutrients, including dense, and as we talked about, there's also the galactose, which is sort of we're not able to break the bonds and digest them. Source of the carbohydrate in a pyramid setting, again, I sort of went through this a little earlier. Fruits, vegetables, grain, and milk, and that's about 160 grams of carbohydrate. One thing I want to mention here is that there tends to be a lot of, at least from what I'm hearing from patients that are in the office, coming in with this piece of paper and say, I've taken my food diary down, and how many grams of carbohydrate do you want me to not go over? I'm not sure if that's an actual a precise number. I think what's more important is that as to what percentage of that of my total caloric intake, what percentage of it is coming from carbohydrate. So if I'm having 1,000 calories and 90% of it is coming from carbohydrate, there's a problem with it, no matter what that percentage is. I think there's too much emphasis placed on hitting these absolute numbers, and I'm not sure if there's any science behind it. And if anyone knows of any science, then I would like to learn and read about it. But what's more important is to make sure that, for example, in a form of a protein supplement, patient may come in and say, I've found this protein supplement that has 30 grams of protein, but when you read the label, there's also 30 or 40 grams of carbohydrate in it. So you have a 1-to-1 ratio of protein to carbohydrate that may not be as beneficial compared to a protein supplement that I have that has 20 grams of or 10 grams of protein, but has 5 grams of carbohydrate. So again, it's not necessarily the absolute gram of the carbohydrate versus a percentage of the total amount of calories taken in. To increase fiber and complex carbohydrate and to reduce sugar, eat more whole fruits, vegetables, legumes, and whole grains. Eat less processed food and white flour and rice, and drink less soda and fake fruit drinks. So this is sort of generally what's recommended. Here's what my spin would be: have no sodas and have very little fruits. It is okay to have some fruits, I think, and I think healthy small volume of fruits, in fact, in duodenal switch patients can be replaced, can be used to replace the satisfy the craving for sweets. I think maybe a pear or an apple or an orange is far better than a Kit Kat bar and a Mars bar or a bunch of Hershey chocolates, for example. Fiber types and actions, they're soluble and insoluble fibers, and they essentially have to do with the types of the bond, those two chains that are connecting those two Lego pieces together, and whether our body has the ability to break them or not. There's a whole aspect to fiber that goes above and beyond the problems that may be causing in the duodenal switch patients that are all beneficial. Those include things like reduction in colon cancer, because they essentially allow for earlier and more regular evacuation of the colon, so the colonic mucosa is not exposed to as many toxins and carcinogen. It allows for easier the digestion of the food because of the bulk and its ability to hold water, diverticulosis, and sort. And they also are able to chelate and hang on to cholesterol and fat, so you're not absorbing as much. So there's an overall cardiovascular prevention and cardiovascular disease reduction in rate. Cancer that's in a form of 1,000 unit in the U.S. lungs, breast, and prostate, and colon cancer in male and female are regular, and it is the fourth most common type in the U.S., second most common cancer death in the U.S. Women less likely to get than men, and this may probably has to do with the fact that men are more usually constipated than female. The patients who've had the duodenal switch operation should be screened for colonic cancer independent of their weight loss surgery history. Nothing we do with the duodenal switch, with revision from gastric bypass or the sleeve operations, does anything to the colon. So as far as screening is concerned, as far as anatomy is concerned, everything is still the same. One variable is that the patients with duodenal switch operation, because of the nature of the bowel function, they may require a little more aggressive bowel prep, I guess. That's how I would put it in. So maybe instead of 2 days of the bowel prep, a patient with DS should be on a 3 or 4 day of bowel prep with a lot of water in it. The risk for colon cancer increases as patients have high fat diet, high animal-derived protein diet, because these are our promoters of carcinogen and toxins. So before anyone who is on the other end of this webinar starts getting all excited, worried about colon cancer, it's important to put things into perspective. One of them is that all of our data and understanding early on comes from non-weight loss surgical subjects. I am aware that, like last year, there was a publication that talked about issues potentially causing colon cancer in patients. I think that's just one study that I'm aware of, and I think there's more said to be than this making one risk. Overall understanding of our colon cancer is that a continuous exposure to carcinogen and toxins is what drives this the risk up. And if I have healthier, more repetitive bowel movement, I reduce the risk of the colon cancer down. The issue with the weight loss surgical study that came out talking about possible increased risk in colon cancer had to do with the unopposed exposure of the mucosa of the colon to the biliary salt that follows duodenal switch when the biliopancreatic lymph feeds into the small bowel. And I think that the mechanism are different, and there may be two different pathways to colon cancer risks. But as of today, right now, our understanding is that if I have regular bowel movement and I'm not constipated per se, then generally I have a lower risk of colon cancer. So having a high protein diet in a DS patient is not the same as not having the DS and having a high fat diet or high protein diet, which increases your risk. I can also reduce my risk of colon cancer with high fruits and vegetables. Again, all of these things go into not only keeps me regular and I'm having multiple bowel movements, but a second step may be that healthier plant-based material may have more antioxidants, which is essentially protective of all types of cancer. Physical activity also reduces risk, and with all of the studies out there, even going back to the NIH's position, is that reducing weight as general reduces pace of types of cancer, be prostate, colon, lung, and breast in all subjects. The bulking action, it's a positive action. It could replace the high-calorie food. So if I eat a large salad, it'll fill up my stomach sooner versus it may not have a lot of calories. Speeds flow through the intestine, less constipation, diverticulosis, and negative effect if it's high in fiber may decrease the nutritional intake, which is what we always have to worry about. And if it's vegan, if in a patient who is childbearing and may become pregnant, the nutrition issues becomes even more pronounced. If I have too large of a high bulking types of complex carbohydrate that may not be absorbed easily, but they're also not as nutritious. The binding action, a positive effect can tie up some carcinogen and reduce, and cholesterol, as we talked about, reduce the cardiovascular risk. And negative effect is that it also binds some mineral. And if I'm having too many bowel movements, and again, I'm losing some of the nutrients. I already talked about this a little earlier. Lactose intolerance, missing or low in lactase, a particular enzyme that allows us to break down the chemical, the bond between the glucose and the galactose molecule to be able to absorb that. And if lactose passes to large intestine, then the bacteria that has actually the lactase is able to break it down. And then when they break it down, if you recall on the very first slide, on the first lecture, on the first series of the slide, it says, carbon dioxide plus water ends up being the carbohydrate. So you have carbohydrate and you go that chemical pathway backward, you form water and you'll have a lot of CO2, and that gas is what essentially will cause the gas and cramping and so forth. 70% of the world's adult population is lactose intolerant. Does not usually affect people of Northern Europe, Middle Eastern, Central African ethnicity, and the question of this is not clear. There's some people have talked about the implication of our milk that's homogenized, essentially sterilized. Part of this may also be sort of use it or lose it concept, where there's a lot more in general, because of the antibiotic that's being used in milk production and antibiotic that's been used in our GI tract may have changed the entire milieu to eliminate the enzymes that we're not able to break down the lactose. Dairy providers, 20% protein, zinc, magnesium, calcium, vitamin D, and B12, and that's sort of where the lactose comes in mostly. Use of the dairy product, milk, most likely to cause problem. Again, we're talking about the milk in the form of lactose as a type of a complex carbohydrate molecule. Cheese, most lactose separated out in processing, and yogurt. Bacteria breaks down the lactose and the lactase. This is why when in our workbook, in our dietary instructions, we tell patients you want to avoid lactose, and then the bottom line, the next line to it says, yeah, but cheese and yogurt is okay. It may appear confusing, but the slides tend to, what I'm trying to explain is by the fact that yogurt, for example, because it has bacteria in it, and that's essentially a rotten milk, you already have broken down with the enzymes, with the bacteria, the lactose, so you're not going to get the gas and the lactose, the symptoms of lactose intolerance you would get with yogurt, with milk, and you won't get it with yogurt and cheese, for example. Hypoglycemia, which is sort of the low sugar symptoms, are the symptoms of hypoglycemia. It's not a condition, it's the sort of the end result of a low blood sugar. This is usually seen in multiple variation. In our practice, most commonly we see this in patients that have had gastric bypass and they've experienced the dumping syndrome, which one of the variable with it is the low blood sugar. Another one would be patients that have length of their bowels with the duodenal switch done in such a way that it doesn't allow them for optimal absorption of the fat and carbohydrates. So they may have too short of a alimentary limb, but percentage-wise longer common channels. So they may or may not have lost the weight enough, but they find themselves to have repetitive episodes of hypoglycemia. That's because their alimentary length is such that it doesn't allow for them to absorb enough carbohydrate to be able to maintain normal blood sugar. Last but not least would be patients that have had duodenal switch early on, and they're just not able to replenish after that glycogen source of the sugar that was in our liver and it's been depleted. They don't have enough intake to be able to maintain their blood sugar. It's a transient symptom itself because over time then the body shifts to other sources of energy. The balance between insulin and glucagon stabilizes. Symptoms include significant hunger, fatigue, headache, dizziness, anxiety, and sweating. If it goes untreated, confusion, amnesia, forgetfulness, seizure, and loss of consciousness may ensue. And as a side note, which is why when I operate on diabetic patients and they go home, I'm much more comfortable with their blood sugar running higher than normal versus trying to micromanage them into a lower level and then have them potentially drop their blood sugar and then pass out and have seizure and so forth. Diagnosis will require a number of controlled, blood sugar testing and glucose tolerance test and so forth. There is something called a true hypoglycemia, which is actually an excess secretion of the insulin due to tumor. You see this in cases of insulinoma, versus reactive hypoglycemia, which is what we talk in cases of dumping syndrome, where the patients actually have normal blood sugar, and then when they have a large sugar intake, their insulin production overreacts and drops the blood sugar down. And there's a condition called mycelioblastosis, where maybe an overexcitable pancreatic cells that responds in an exaggerated fashion if there's a high blood sugar coming in, and this is one of the complications that's associated with gastric bypass patients. The symptoms of this fasting symptoms 8 to 14 hours before eating, and you have to watch the blood sugar, see what's going on. When the liver glycogen depletes, and as I said, that's sort of the very first store of the blood sugar, it's in the liver. Remember, 2 glucose molecules. When that's depleted, and then the body starts driving, going to protein as a source and runs the protein through the pyruvate cycle, Krebs cycle, recycles it, and essentially makes the glucose molecule after complex pathways. And that becomes a secondary source. If that pathway is depleted, then the patient becomes hypoglycemic. So from a practical perspective, which is why we recommend patients to have frequent small meals to avoid these ups and downs of the blood sugar, and also keep their protein up to prevent from the body, when needs extra glucose in short-term spurts, start burning the body's own protein and actually use the protein. So as the slides also says, if you just sort of look at that second part, it says conversion of the protein to glucose. I've already talked about this previously, but I want to use this again to mention that protein is good. A little protein may be a little better. A lot of protein may not be very good. Excessive amount of protein at some point will tip the scale in the favor of starting to form glucose, which gets stored as a fat eventually. So 100 grams of protein is good for me. 1,000 grams of protein is not good for me. And we need to sort of drive this into a reasonable, rational way. The same pathway, the same theory also applies in maybe a little fat in a form of a few slices of bacon or sausage link every morning is good, but to have an atomic bomb of half a pound of butter with deep frying a whole bunch of sausage link and eating it may not be good for me. Treatment of hypoglycemia would be small, more frequent meals with emphasis on complex carbohydrate. The purpose of the complex carbohydrate, and not necessarily the fiber type that we can't break down, would be to make sure that the body avoids having those highs and lows of the blood sugar that can cause spikes in insulin and glycogen release. Diabetes mellitus, we already talked about this real quickly. Symptoms may be hunger, urination, and thirst. And type 1 diabetes represents about 20% of the cases. Patients that are considering weight loss surgery who may be diabetic, it's important for them to appreciate that, if the scientific environment knew about diabetes what we know about it right now, we would probably not call this type 1 and type 2 diabetes. And in fact, there is something called the type 3 diabetes, but we would have called them disease A, disease B, and disease C, completely different things, because even though the end result is you have an elevated blood sugar, the pathophysiology behind them is so different and the treatment options are different. Of concern to us is patients that have weight-related type 2 diabetes, and because of continuous overstimulation of the pancreas, they get into a phase of pancreatic burnout, and they have no more cells left in their pancreas to be able to produce the insulin. So now that's when they start going from a type 2 diabetic to become a type 1 diabetic. A type 1 diabetic patient, whether started as a young age, or a type 2 diabetic patient who's on insulin, may have a much hard, type 1 diabetic will not theoretically be cured by any weight loss surgery, period, because the defect in the pathway is lack of insulin production or inadequate insulin production. A type 2 diabetic patient who's on insulin, who's gone down that slippery slope, may be able to get off of the insulin, or may be able to get significant lower insulin requirement. And if they're purely type 2 diabetic, in majority of cases, dual switch solves their problem. Type 1 diabetic has been associated with viral and autoimmune diseases. And again, this is not the treatment for true type 1 diabetic patients, that's generally pancreatic transplant or islet cell transplant. Short-term consequences is loss of muscle with type 1 and excessive fat use, ketosis, where sort of the ketoacidosis that the musky smell comes in, and so tend to be thin and losing weight, and if uncontrolled can lead to death and coma. Treatment is insulin shots, and as I said, balanced tissue transplant, and you have to keep an eye on the insulin and dietary carbohydrate. Alcohol also needs to be factored in a form of alcohol is an easily absorbed source, and that has to be avoided. Type 2 diabetes, about 80% of the cases. The rate increases with age and with obesity. The rate of type 2 diabetes in the 90s has gone up significantly. And there's even though in medicine there's a saying that, if two things occur at the same time, doesn't mean that one is causing the other one, but there is an association potentially that our high corn syrup use and artificial sweeteners have probably not helped, if not directly or indirectly contributed to the problem. There's a stronger genetic and familial link than type 1 diabetes. 6% of the Caucasian, 9% of African American, and 8% of the Hispanics have statistically shown to have type 2 diabetes. Type 2 diabetes is the insulin resistance disease, where it produces insulin and the body doesn't know what to do, as I sort of showed earlier drawing on this. Treatment includes hypoglycemic agents, and in the last probably 5 years or so, there's a whole spectrum of oral medications that have come up that essentially address each and every individual part of the pathway. There are some that stimulate the receptors to be more reactive. There are some that sort of create an attachment to the receptor that allows the receptor to still function even though it's not attaching, and so forth and so on. And they all have all their benefits and downsides. And if you look at the treatment of diabetes right now, to look at what the treatment of high blood pressure and hypertension was 50 years ago, it was realized early on that the treatment of hypertension should be multimodality, where if a patient is diagnosed with high blood pressure, they're placed on a diuretic, they're placed on a beta blocker, they're placed on an ACE inhibitor. And it seems like the effect of the treatment for high blood pressure is much better when you have multiple class of medications at the lower dose than one at the very high dose. That sort of tends to be the realization nowadays when it comes to the diabetes. The same problem, the same solution, that if you have multiple medications at the lower doses tend to work better. And we already talked about that. Long-term complication of the diabetes because of the capillary changes, no matter whether type 1 or type 2, you may get blood vessel non-compliance, and this will lead essentially any organ that has blood vessels and there are small blood vessels. Because of the loss of elasticity, you'll get problems with it. Be heart, kidneys, eyes, and the blood vessels that go to the digits and the toes and result in amputation. Syndrome X is what we see frequently in female population who is considering weight loss surgery. It's an insulin resistance, 25% of the population, higher in non-Europeans, triggered by, aggravated by abdominal obesity. So, female patients that have more of an apple shape versus a pear-shaped distribution. Additional risk factor to this is sedentary inactivity and smoking. Symptoms include elevated insulin, glucose, and triglyceride. And they also significantly higher risk of cardiovascular disease, type 2 diabetes, and hypertension. Syndrome, if you have two individuals that have the same weight and BMI and things like that, and you have a patient that has also on top of that has elevated triglycerides, have central obesity, then they are also at a increased risk for cardiac event and so forth. Simple carbohydrate particularly are a problem in these patients. Syndrome X patient in females are also known to have issues with infertility, menstrual irregularities, which in all cases are recommended to avoid all types of simple carbohydrate, sort of sugars and breads and pastas and things like that altogether. Glycemic index is sort of the scale based on which we talk about how the glucose is absorbed and processed, measure of a food's relative ability to raise the blood sugar. In general, what I say here may be a little different than what an endocrinologist will say, because there's our take of glycemic index is practical to some degree for a weight loss perspective, where an endocrinologist may have a more academic view of this. So implication are patients that have high glycemic indexes would cause more problem with patients because they'll raise your blood sugar higher. So an example of that would be a higher glycemic index food, maybe sugar, potatoes, and rice, where lower than would be lower glycemic index foods, maybe things like dry beans, pasta, and whole wheat. From a weight loss surgical patient, the downside of having a patient high on beans and whole wheat may be worse off the gas and the diarrhea, which complicates things, whereas small amounts of healthier sugar may be healthier in a form of a little honey in my coffee or tea to maintain a blood sugar at a normal level. What are the common themes relative to carbohydrate syndrome X, diabetes, and hypoglycemia? It's the simple carbohydrates and poor meal pattern that complicates the problem, which is what we always recommend, having small frequent meals to avoid extreme spikes of the insulin and glucagon from one part to the other part. Sugar and health risk. Obesity, if excess calories are taken in and a patient has the genetic predisposition to obesity, then all of these extra calories are converted to extra sugar is converted to extra calories. What we've also done, unfortunately, is that we, in general, from a grocery shopping experience, we try to avoid having regular content food, and we have gravitated towards the low-fat meals in general, and that means that we've offset that by having high carbohydrate diet. As I said a little earlier, I do not have a particular number recommendation. I think it's very important that the patients appreciate what the percentage of this would be, about 20-30% of your total intake versus an absolute number. hyperactivity sugars and stimulant, as you know, on one of the earlier slides we talked about tooth decay, and the bottom summary line is that the sugar and carbohydrate processing in our body is an empty calorie, and whether weight loss surgery or not, it really is detrimental to our health because of not only from its basic energy excess point of view, but also from all of the other issues that it can cause, whether directly or indirectly, with regards to increased cardiovascular risk and so forth. Artificial sweeteners, non-nutritive saccharine, and the nutritive ones would be things like mannitol and sorbitol. Essentially, all of these things in one form or another are chemically made, and I think any benefit, potential benefit that may be, which there is hardly any, is completely offset by their chemical reaction that they can cause. NutraSweet and aspartame is essentially 2 amino acids with an alcohol molecule. Very interesting that I sort of pulled this out from their websites too, that there's a significant correlation, and some data said between 30 to 40% of patients will have headache, seizure, dizziness, and patients that are labeled as being very sensitive to this. The key with the amino acid is that those amino acids are extremely small molecules that tend to be able to cross a number of barriers in our body, including the blood-brain barrier, which may explain why there is a seizure issues with this medication. People with PKU should also avoid that. In general, essentially, diet sodas are full of this aspartame, and I think it should be avoided at all costs. Long-term risk to the children with lifelong exposure of carbohydrate intake is something that we need to all bear in mind. Obese patients will have obese children. Part of that may be concept of neogenetics in above and beyond the food and activity level. Pregnant women should, with the changes in their blood amino acid mix and affect the fetal intake of the amino acid, as I said, there's still some studies that have shown that, females should postpone pregnancy till they've lose weight and then get pregnant. Who will benefit from all this? Essentially, we should all think about healthier moderation in diet, water, protein, everything else, no artificial sweeteners, no carbonated drink, eat frequent meals, and Elmo diet. And if we control our weight, at least from a type 2 diabetes, there's much less chance of becoming diabetic if our weight is controlled. I'm hoping that people are still awake and no one fell asleep on it. I know it was a long discussion. I'm sorry? Very good. Any questions? Didn't see anything.
Mm-hmm. So I think the policy of carbonated drinks, but what about consuming?
No, I don't think there's anything wrong with having tea per se. Other than the fact that excessive amount of tea has oxalate, may predispose to kidney stone formation, and the caffeine in it. So, and I also, as I said, I'm not philosophically recommending anyone avoid sugar. I mean, it's okay if you want to make tea with a tablespoon of sugar, that's better than having some artificial sweeteners in it. But if you want to have it unsweetened, that's okay too. I don't think there's anything wrong with tea. Just need to bear in mind that oxalate, kidney stones, and also in general, a lot of caffeine, even in tea, may tend to dehydrate you more than the volume you're taking in. So if you want to just make a very light watered down tea just to have a different taste, there's nothing wrong with it.
Some people consider sugar to be a trigger.
In a form of I don't know. I mean, I don't know if there's any. I don't know if there's any scientific evidence or anything like that. But I guess the question is whether sugar itself is considered to be a trigger for carbohydrate binging.
It makes sense.
Yeah, but at the same time, I would say that if I really was craving some carbohydrate, a small piece of carbohydrate or some reward may be enough to, I don't know. I'm not aware of if there's any.
And then my second question, follow-up question, on counting carbs. So you said carbs is a total percentage of the diet. What's the ideal percentage? I mean, is it 20%?
20%, give or take, and here's my disclaimer. We really don't know. There's no hardcore studies out there. Everything that is in the nutrition talks about that pyramid, and that pyramid assumes that we're all 35 years old, we're all male, we're all muscular, and none of us are, and and on and on and on. I mean, that's much more of a petri dish test tube experiment than a practical observation out there. So you take the variability or lack of objective measurement in that pyramid, and you take that even one step further by having changed our physiology, and we don't know what we absorb, how much we absorb, and this and that. So I think the issue is that there's very little science. There's some hardcore data that we know that our brain needs a certain amount of glucose to function every day. You cannot go on a zero amount of glucose in the brain. You need about 150 grams of sugar to be able to function in the brain. And I've said this before. A trick is when you have a medical school test, you don't want to diet and go take your test. You'll flunk. You have a Kit Kat bar or a Mars bar before you walk into a test. You need that rapid sugar to be able to process. If you have your brain starving from glucose, you'll eventually have to use the ketones in the body to eventually have the brain use the ketones as a source of energy, which is a slower process early on until the brain gets used to it long term. And that's the key, that there's certain, the red cells, as we talked about, needs the glucose. Muscles early on need some glucose. So you do need some glucose to be able to function. And I know there's a note here that says, someone had to keep their carb to 5 to 10% to lose weight. And, I think I'm not sure if that makes sense, because I don't know what the total length of the bowel was. I don't know how much was the common channel length. I don't know how much of it was absorbed. And again, this all has to do, in my practice, I do not recommend patients cut down on their carbohydrate into an absolute number. I always say water, protein, everything else. I mean, you guys have seen that. Water, protein, everything else. It works. If your common channel are made based on a percentage of your total length, this will work. Water, protein, everything else, and about 20% of the carb, and then just eat healthy. I don't think we need to resort into extreme things, because then they'll also have their own issues too. How's your diabetes? Last hemoglobin A1C? Good? Very good. Yeah. It was what? On a bucket of medication. Yeah. When it comes to absorption of the protein, I guess there is, in general, from a receptor perspective in our GI tract, the more variability you have, the better you're able to absorb things. So, from a nutrition point of view, I'm better have to have, chicken today, beef tomorrow, and fish the day after in order to rotate. So whether a whey isolate protein, depending on whether it's what's the word I'm looking for?
No.
Yeah, not the bioavailability. Well, not isotonic. No, I'm having a brain fart. Oops, did I say that too loud? No. So it'll come to me in a second. So depending on how the proteins themselves are broken down into, in general, it's healthier to eat, meal-based proteins for it to be able to absorb better on a variability. The reason why we recommend patients to have protein supplements early on is because it's very hard to consume enough food to get the protein in. So I think in general, a natural source of protein at any given point in time, if you can take enough of it, is far better than the supplemental forms of it. Isolate, protein isolate, that's what I was looking for. So in the form of an isolate, it came to me. Oh, there it is. If an isolate, because it's essentially smaller broken down part of it, your body does, in theory, isolates get absorbed better. And so you can benefit from that absorption better, but from a big picture type scheme of point of view, you are better off to have different variability. So what do I do? Right. So what do I do tonight? I think if I'm able to eat normal size meals and I'm able to get to the protein that I can eat the normal meal size, I will just stick with the meals. If I have to have a little supplemental protein, then I think whey isolate supplements will be good things to have.
A lot of the studies are protein shakes and
Right. And, 2.5 years out is still sort of, you're out there enough that you still have metabolic requirements that may or may not be as visible. I mean, we see patients that are 4, 5, 6 years out, and now I've been on my own sort of a year or so. All I'm taking is my multivitamin, calcium, and the vitamin D and vitamin E or whatever I need to, and I've been able to take enough protein by meals to be able to absorb. So that is very reasonable to be 2 or 3 years out, still required to have some protein supplements here and there. Yes. So in patients that have to, isolate proteins may also be good in patients that are, early on, maybe trying to bring up their proteins. If a patient is far out from surgery and they're still having to rely on protein supplementation, someone really needs to consider about maybe lengthening the common channel and resort to other things, because at some point your body needs to be able to do this on its own. And whether there is common length issue, whether there is a need for pancreatic enzyme supplementation, you have to, I think we need to think about the big picture in a form of whether my length of the bowel needs to be adjusted or not. Yeah. Right. I mean, as I said, if a patient has to have protein supplements many years out, then consideration should be given for lengthening the common channel. I should not be more than 5, 6, 7 years out, and I still have to resort on protein supplements to maintain my normal numbers, essentially. Any other question? Very good. I will, if there's nothing else, I can stop this. And if you have any questions, text or ask, and drive carefully and have a good day. Huh? You're staying here?